Okay, we are up running. Hey everybody, I am Didrik, and I've been invited by Christian to come and talk to you a bit about Thompson technique. As you're probably aware of, there's a lot of different techniques out there in the chiropractic world, and you have, for instance, Gonstead, upper cervical, the activator, Cox, etc. And one of the techniques is Thompson. So that's what we're going to do today. It's a brief intro, so I won't go too much in depth, but we're going to have hope that you can walk away from here with a better understanding about Thompson, how we can approach Thompson, and if you want to know more, obviously later, please be in touch. But for now, it is a brief introduction. As you probably know, as you heard, there's several different chiropractic approaches, and the beautiful of this profession is that we have you can approach it in so many different ways and have great results with all of them. That's how effective this profession is. So either if you're doing Gonstead or you're doing upper cervical or you're doing Thompson, you will have great results because you are having an impact on the nervous system and the brain. First of all, we need to define some terms, because I'm going to say some words and some words here today, and if you don't understand them, and if I haven't explained them what they mean, it can be a bit misleading, because words are super powerful, so we need to be sure to determine the words that we're using. So first of all, we need to define what we are doing. We need to define chiropractic. So before we do anything of the Thompson, we just need to define a couple of things. Through my time in uni, I didn't know what chiropractic actually was. It was later on that when I started to do some research myself, that I actually figured out what is chiropractic. So to define it, we just need to go through it and see what it is. Yeah. So first of all, we are a health profession, but there are many other health professions. So we need to be more specific than that. We are. Some people say that we are a profession that works with the nervous system, or works with bones, or works with joints. There are very, very many professions that do the exact same things. So we need to be very, very specific of what we're doing. So let me define it here for you. When I'm saying chiropractic, it is a profession, a health profession, that is concerned about detecting, analyzing, and correcting vertebral subluxations. So let me just repeat that for you. We are a healthcare profession that are concerned of detecting, analyzing, and correcting vertebral subluxations. And now you hear me saying subluxations, and I guess still in school it is they are not talking about this, or they're saying we're not using that word. And I think probably now the schools teach you something about there is an partial or incomplete dislocation of a joint or of a bone. And that is probably the latest update from the medical profession. However, the medical profession has changed their definition of a subluxation since the subluxation was included or introduced for chiropractors. So if we go back in time, the subluxation, the medical definition of a subluxation was different. So why do I use the word subluxation? Well, it is very important to if you want to explain to someone that you know what you're talking about. And if you would like to define and explain chiropractic to, if it is your neighbor, your doctor, a friend, your client, it is very important that you understand what chiropractic is. So if we can't define it and we don't know what it is, how can you then expect our clients to understand what chiropractic is, right? So what is a subluxation then? Let's define that. Obviously, I would have loved to have this discussion in person, so we could have talked about it and listened to what you said. But a subluxation is an abnormal articulation of a joint that has detrimental effect on the nervous system. Let me repeat that one more time. It is an abnormal joint articulation that is detrimental to neural integrity. That is a better way to say it. And then we have a vertebral subluxation. So subluxation you can have throughout the whole body in different joints. When it comes to vertebral subluxations, that is an abnormal vertebral joint articulation that is detrimental to neural integrity. I hope that makes sense. And when I'm saying subluxation now, this is what I mean. This is what I'm looking for in the spine. And I'm not looking for anything else. This is my job. This is what I'm looking for. And in Thompson technique, we're using the word subluxation very, very often. And that is what we are correcting. Another thing we need to define as well before we go forward is, are we doing a correction or are we doing an adjustment? Because they are two different things. So we chiropractors, we don't adjust anything. We correct subluxation, and then the body do the necessary adjustment itself. Because you don't do those adjustments. That's your body and your brain that is you. After having that correction, it can adjust to that. All right. Why does a subluxation occur, by the way? Well, it is the inability of the body to comprehend itself. So many people saying that it's stress that is causing the subluxation, which is partially true. However, we are experiencing stress every single day from gravity, etc. And if we weren't able to deal with stress whatsoever, we would have been subluxated all the time. So it's important to understand that stress is a factor of it, but it's the body's inability to comprehend itself. For instance, if we are having an accident, and a car accident, and there is a huge force to your leg, and you break your leg, well, that's the body's inability to comprehend itself, because the force is so high, so it can't withhold that stress. When it's a more of a micro trauma, maybe acute, well, if it is a small micro trauma acute, well, then it's not a biggie. But if that becomes chronic, over time the body is not able to comprehend itself, and that's when subluxations occur. All right, now it's easier to understand what I'm going to say for the rest of the presentation. I'm not sure exactly how long we will be going on here, but I guess another 30 minutes or something like that. All right, Thompson technique. As I said in the beginning, this is purely an introduction to Thompson. There are several different chiropractors that has implemented new techniques and new theory. And that is just because when Clay Thompson, the founder of Thompson technique, when he started it, like they didn't have the knowledge about the neuro, about the biomechanics. There's so many things that we have figured out since then. So other people has taken the technique a bit further. But he was the founder, Clay Thompson. We have, as I said, several other chiropractors that have their approach to it. And then we also have John Menardi. He is now, at the moment, lecturing in Thompson technique, John, with the Menardi integrated systems. And if you would like to know a bit more in depth about Thompson technique, I highly recommend you to do his level 1 Thompson seminar. It is really, really, really good. He goes much more in depth about the neuro, the reasons why we do it, and he can explain everything. That is another little thing I would like to advise you about is if you, no matter what technique that you would like to work with, if you know the biomechanics and you know the neuro well, you can explain everything you're doing to everyone. So if anything, if you have to defend yourself in some way or explain to someone why you're doing this, why you're doing that, if you know the neuro and the biomechanics, you can explain everything, and everything can be justified. And that is one thing that is so great about Thompson, is that you can justify every single correction that you do. We'll go a bit more in depth about that in a bit. Also, when it comes to Thompson, they use a lot of drops, especially Thompson and Menardi. There are more manual corrections you can do as well. I'm a bit more fan of that, so I'm doing a lot of manual corrections, not so much drops, but I also use drops. So there are different ways that you can use Thompson. If you want to follow the strict protocol, then they use drops on almost everything. But this is approach you can have different type of correcting approaches. It doesn't have to be just the drops itself. Also another little fact about Thompson. So they're using the drops, and you can ask, why are they using the drops? Well, it started off with that Clay Thompson, when he graduated from school, he had a bench, he bought a bench that wasn't very well. So every time he did a correction of the neck and the cervical headpiece, it collapsed. And over time, when he got some more money, he bought a new upgraded bench that didn't have that fault on their cervical piece. But his clients started to complain about it, that they didn't feel that well and feel that good. So he was interested in that and developed further the bench that he was using. And also when it comes to the analysis that you do every time you see the client with the leg length difference, the reason why that was introduced was because of there was a chiropractor that was observing the legs of the client, because one client had a shorter leg, and then the phone was ringing in the reception, and the client looked towards that the phone, and then the chiropractor saw that the leg difference changed when he was looking to one of the sides. So he had to he did more investigation in that, and they started to figure out, okay, what is happening with the leg length. You might have heard from other chiropractors or from your tutors that a leg length check is not very good, but I was taught that in school as well, with no explanation why. And there is a lot of research out there now that shows why a leg length check is actually very accurate. Why do we see a leg difference, for instance? Like, obviously you have the structural and the functional differences. A structural difference is that we all have, actually. Most of us have a small difference, but the body compensates for that. But most of people have a leg length difference because of it is a functional difference. So something is interfering with the nervous system and how the muscle contraction is on that side of the body. And that goes from all the proprioceptors that is within the body. So the muscles and the joints, the ligaments, the tendons, and also the Golgi tendon organ. All of these sends a lot of signals to the brain, and when we have a subluxation, the brain is flooded with negative information. We don't have to go too much in depth about what type of information that is, but there's a lot of negative information, and that goes to the cerebellum, to the thalamus, and also to the cortex. And as a result of that, because the conductor of the body is the brain, it sends out a lot of negative information back, compensating signals. What I mean by that is, if something is not working somewhere, the brain gets that message, and then it has to send a message back to compensate for that thing that is not working. And that leads to postural changes in the postural muscles, and contraction of them, but also the other muscles within the body. And then we can see on one side that one of the legs comes up because of that contraction of that muscle. So it's a very effective way to see and to justify where you have to correct. But obviously, before we do anything of that, when we see the client the first time, we do a full examination, where we get the full history of the client, and we get all the details we need to know. Is there any contraindication, etc.? And then every time we see them after that, we're using the leg length check to justify which area we are correcting. So the leg length check is just a day-to-day justification, but we also do a full intake when they come into our clinics. All right. What is also important to know about Thompson is that it is divided into primary, secondary, and tertiary areas. So first of all, we're checking the primary areas, that is the neck and the pelvis, And the reason why that is the primary area is because that is where mostly of the neuroreceptors are located. The density of the receptors are located mostly there. It's also in the other parts, but that's where the density is highest. That means that the neurological impact is highest in that area, and that has to be checked first. So we're checking the neck and the pelvis first. I will go through in a bit how specifically we do it, but that is the first area. The secondary area is the lumbar spine and the CT junction, so the cervical thoracic junction, and at the end we have the thoracic itself. That is the third area. So that is the way that we operate. We always have to correct the most important subluxation first, and the reason why is because if we correct a primary area first, a secondary or a tertiary subluxation might resolve itself because it's been compensating in that way. So you will know on the leg length when you have to stop and when you have to continue. It's a very powerful tool to use, the leg length check. But that's also why it's divided into these three categories. Then you have the extremities. I'm not going to go through that today. Thompson protocol with Minardi has created an extremity approach as well. That is always done, when it's done though, it's always done after the spine. So the spine is completely checked first for any subluxations before the extremities are checked. And the reason why, and this is very important, if you go to an area, let's say a shoulder or whatever, and do something there without having a proper nerve supply to that area, you can actually do more damage than good. Maybe that shoulder is in that position because of the spine, right? Because all the nerves comes from the spine. So it's very important that you understand that. If you want to do anything with outside of the spine, you always have to clear out the spine first. But in general, like on the basis, Thompson is a full spine approach, and then other chiropractors have added on some extremities later, but that is not the most important. It comes always last if it is addressed at all. All right. So let's go. Let's see what we're doing then with the clients when they're coming in for a normal correction. So a typical scenario. I will make a scenario for you and just go through, like, very basically how you can address the whole spine with this technique. Bear in mind, there is a lot of different subluxation that you can have. I will go through the very, 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 very common, and I will mention a couple of others, but just so you get the impression of what it is. But it is very detailed. There's quite a few in the neck, quite a few in the pelvis, and I will just mention them briefly. Hopefully I can come and show you one day at campus how to do some of the techniques, so you can get a bit better understanding of how it works, but I will try to explain as good as possible. Okay, so let's say that the client comes in, lays prone on the table, face down. Before we do anything, it's very important also to know that the leg check is very important, because if you read it wrong, you can get the wrong reading. So you can start correcting areas or subluxations that is not supposed to be corrected. So bear in mind when you do this, when you practice on this, if you do the Thompson, bear in mind that you have to do this very accurately, the reading. Anyway, they come in, and the clients comes in either with even legs or one short leg. That is what you can see the first time they come in, or whenever they come in. If they have balanced legs, it is either that it is perfect, so you don't have to do any corrections, or that it is a occiput problem. We're not going to go into details about occiput today, but that is, if they're balancing out 100%, that is usually occiput, or that it is normal, so there's no subluxation needed, no corrections needed. What we usually see is that one leg is pulling up short, and as I said, that is the signal, the negative signal that is sent to the brain, and all that muscle tension on that side is a bit higher than on the other side, and therefore that leg is being pulled up a bit. the first thing I then see is, okay, this is either a pelvis or a neck subluxation. And the first thing that I have to do is to make sure to see, okay, is it a neck or is it a pelvis correction that I need to do first? So I ask the client to look to the left or to the right first, doesn't matter. And if they balance out on one of the sides that they're looking, that means that they have a subluxation in the neck that needs to be corrected first. If they don't see any change, if you go to the left and to the right, then it is a pelvis subluxation. For now, for the simplicity, let's go for the neck first, and then we can work our way down to the pelvis afterwards. So, client comes in with a short right leg, looks to the left, nothing happens. Looks to the right, balances out. Yeah? So when the client looks to the right, legs are coming into 100% imbalance. If they're coming almost into balance, that do not count as a positive finding, and then you go on to the pelvis. But if it balances 100%, then it is a neck subluxation. So what you do then, you have to use your palpation skills. And this is also a very, very important thing, because you can know all the procedures by heart, but if you don't have good palpation skills, the reading is a bit useless. So they're looking to that side, you're palpating then the lamina pedicle on the opposite side, because that is where the subluxation is. But it's because they're looking to the right that we're calling this a right cervical syndrome. So you palpate from C2 to C7, and the reason why you're looking from C2 to C7 is because C1 doesn't have that lamina pedicle. In that lamina pedicle, you will find a P-shaped nodule that is very tender and hard. And then you probably know that there's a lot of musculature there as well in that area. So you might feel some tender muscle knots. However, you're looking for that very hard P-shaped nodule. If you don't find it, then the C1 is the indication of the subluxation, and then you have to do an atlas correction instead. But for now, let's see that you find one of these nodule in the cervical, and then you do a correction on that side. Bear in mind that when you're correcting, let's say that this is the C1 and this is the bottom of the neck. You're correcting in this way because you want to correct in the line of the disc itself, of the joint. So when you are correcting high up, you need to go further down so that you can correct upwards, and then when you're in the middle of the spine, you correct more straight over, and the further down you are, you need to correct down towards the body. That will make more sense when you start doing this, but just have that in mind as well. Okay, we now correct on the opposite side because that's where the subluxation is. And again, if you know your biomechanics well, it's very easy to explain why you are doing this, why you're doing that correction, why I'm doing this subluxation. You can justify it very, very easily. So bear in mind that you know general biomechanics of the spine, and that will help you a lot. Okay, so then finish with the neck. I'm going down to the legs again because I'm always rechecking before I'm going on to the next correction. So now the client came in with the short leg, looked to the right, it bounced out, went up, did a correction there on the opposite side. I now look again, okay, still one short leg, client look then to the right, nothing happens, that means we cleared out this side, look to the left, nothing happens, that means there's nothing on the opposite side. That means when there's no change in the leg length when looking left and right, the neck is done. If you then, on the other hand, did the pelvis first and then went to check the neck, and then you see that there can be a difference again. But you need to make sure that you cleared out the primary subluxation first. Okay, then we go down to the pelvis. And pelvis, I have to be honest, I had a very difficult time with the pelvis in the beginning. I did not understand, because I didn't understand the biomechanics of the pelvis. It can be very difficult. It is very straightforward, but if you don't grasp it properly, it can be challenging to understand where to contact and why is that subluxation in that position. Yeah, the pelvis for now, it has a couple of different things it can do as well, but these are the one that you see almost all the time. And that is an AS sacrum. That is the sacral base of the sacrum that has shifted anteriorly and inferiorly. That's why it's an AI sacrum. It can also be an ilium problem where the ilium has gone PI. So then it's a posterior inferior ilium. Also, no, let's keep it that basic for now. Just AI sacral base, and then it's the sacral base that has gone anteriorly and inferiorly compared to the PSIS of the ilium. So just bear in mind that you need some landmarks here. So the sacrum here has gone on one side, has gone anteriorly and inferiorly compared to the PSIS here on this side. If it is an ilium problem, you will see that quite quickly on the leg length as well. So let's take it back again. You're looking at the legs, you're done with the neck, and now you're bringing the legs from extended, where you are doing the leg shake, and up in flexion in 90 degrees. And if the short legs remain short or comes into balance, that means that it is an AI sacral base, potentially, because you need to do a couple of tests. If it goes from short to long, this is now the long leg, it goes from short to long in extension to flexion, this is an indication of a PI ilium. I'm not sure how deep we're going to go into the biomechanics of this, but it is because of the normal biomechanics, the gait biomechanics, that the sacrum, for instance, goes into this AI sacrum, AI position, AI subluxation. Yeah, I don't think we should go any further than that actually, but bear in mind that these two are the most common subluxations that you see in the office. And if you know where to contact and you know the biomechanics, you will understand very, very quickly why you have to do the certain corrections. Yeah, Minardi here has integrated his own, because Thompson had a very he had a way to approach the pelvis in a way that is a bit time consuming, while Minardi has taken it apart and like, okay, how can we do this in a more efficient way? That is purely with the drops, but here again you can do manual side postures. There's many ways to do it. I usually do the pelvis with the drop and the lumbar spine more as a side posture, but sometimes I do a side posture with the sacrum as well. Yeah, so that to repeat that, short in extension to short in flexion means an AI, an anterior inferior sacral base displacement. And then if it is short to long in flexion, then it is a PI ilium. The ilium has gone posteriorly and inferiorly compared to the sacral base. So that's important to have in mind. Also with the PI, there is you can either do a drop or you can do a side posture. There's different ways to do this. But keep that in mind, that those two are the most common ones that we see in our practice. All right, we have then cleared out the pelvis as well, and then that tells us that the primary areas has been corrected. We go down to the legs and check it again. And if the legs now, let's take a scenario where the legs are now in balance, that means that you are both in extension and in flexion. It means that you have cleared out all the subluxation and no more corrections are needed. So that is a very powerful tool with this Thompson technique. You can see exactly when you need to do when there's one correction that hasn't been cleared, or if there's more correction needed. All right. Next area is the lumbar spine. And the lumbar spine, I usually go to first over CT because of the neuroreceptors there are a bit higher than the CT. Often we see when there's an AI sacrum This is a very important thing with the sacrum, is that when the sacrum subluxates, the ilium and the lumbar spine has to compensate. And the reason why is because of their ligamentous attachments, because there are ligaments that goes from the lumbar spine to the sacrum, and it is also from the ilium to the sacrum. So when the sacrum subluxates, the other thing has to compensate, and you should subluxate with it. When it comes to the lumbar spine, if there's an AI sacral base subluxation on the right side, the spinous process of L5 usually deviates towards the same side. Not always, but often. So we can see, I always do this with my clients. I always check the lower part of the lumbar spine first, because if there is almost, I don't know exactly, but it can be quite high percentage that the lumbar spine has gone, on L5 has gone the same way. What I do then is either I do a drop, or I can do a side posture as well, to make sure that we get that vertebra where it should be. What often happens with the vertebrae is that it goes posteriorly and then it rotates to one of the side. So you want to bring it back again, and let's say that it's gone posteriorly and to the side. You want to bring it back to where it should be, and anteriorly. Obviously, this is not the case for everything. In the low back, you have a lot of different things you can have as well, spondies and stuff like that. There are different ways to approach that as well. Also with like a very acute disc and stuff like that. But this is what you see the most. This is what we're going to go through today. All right. If you then do the lumbar spine, let's say that L5 has subluxated, you do L5 correction, go down to the legs again, and the legs still pull short. I would like to clear out the rest of the lumbar spine, so I palpate L4, L3, L2, L1, and see, okay, is there any other subluxations in the lower spine? If not, I go to the CT junction, the cervicothoracic junction, and do a correction there if it's needed. Same here, it usually either goes posteriorly and to one of the sides, and at the end I'll do the thoracic spine. So that is to make sure that we have cleared out everything, and obviously I recheck in the legs all the time, so I see if I need more corrections or not. When we have done the last correction, we usually do little cleanup moves. I'm not going to go into that today, but it is a very, very especially as a new graduate, but I still like it, the Thompson protocol, because I can rely on where specifically do I need to do a correction, and if I know if I'm finished or not. Yes. For instance, let me take an example here with a lot of the school says that you need to do a lot of soft tissue work and exercises, etc. When it comes to massages and stuff, that can be very nice for people, can be it feel good, but there's always a reason why a muscle is tight, and that reason is because there is a defense mechanism from the brain. So let's say that you have a subluxation and it sends a lot of negative information to your brain. Your brain sends negative information out and make a muscle contract in that area, because it has to protect it. That's the only way that the body can protect an area to stabilize it, is to contract muscles, right? So if you're rubbing on that muscle, it might feel good, it might feel a bit less tense, but that same signal, because if the problem is laying underneath, it's still important to keep it tight. So over some minutes or hours, that muscle will go back to that original state again. So if we don't clear out the underlying reasons why the neurological things are happening in our brains and in our body, that compensation will continue to happen. And that goes for the other things in our body as well. When we have these subluxation, there is so many negative things sent to the brain, and also a lot of stress hormones produced. So if we don't take care of the underlying reason, that problem will just keep on reoccurring in that body. So correction is such a powerful tool, and I was very confused when I graduated with like my approach to everything, because there was no one that is like Thompson is a very strict protocol. We take care of the subluxations primarily in the spine, and how powerful that correction is and how much benefit that client will have from that correction is incredible. And you will start seeing it in clinic as well, how much value the client is getting from those corrections. So get good at correcting. Don't be afraid of trying on each other. We were told very early in the beginning not to do any corrections on each other. I have to say, just try. When I was to uni, I practiced with a colleague of mine or with a student of mine all the time. And just get confident, palpate, be secure of what you're doing. The clients will pick up these things easily if you're not comfortable with palpating, for instance. So just get good at that. And I promise you have so much nice things to look forward to. And I think you, even though it can be difficult through university sometimes, you have so much to look forward to. Figure out, do different research. Go to seminars and observe Gonstead chiropractors. Go to seminars and or to clinics and observe people that do Thompson, or if they do Cox. There are so many different chiropractic techniques out there. Be good at that first. I think you will thrive through after you graduate, how great this profession is. So just to summarize what we have done today. Thompson technique is used as a very effective way of analyzing where the subluxations are. It is time efficient, and it will also give you a good indication and justification where to correct. It's also very important for me that we talked a lot about different terms here today. Just understand the terms that you're using, and if your teachers are saying anything that you don't understand, please ask them to define what they're saying, because that will put them a bit on the spot as well to explain to you so they can actually explain to you what they are saying. I hope this made sense. I would obviously, like I said, love to have that I could do this in person, having a discussion, showing different techniques. I know I didn't show you anything today about how we do things, but I explained a bit about it. And if you have any questions, please be in touch. I will give my contact details to Christian. Add me on Facebook or send me an email. And obviously our clinics here in the Netherlands, they are we are using Thompson every day. So if you want to come over and have a look, see how our procedures are, how we do an intake, how we do our corrections with our clients, please be in touch. We are very, very happy to see you. And also, if you just have any questions, please be in touch.